Hopefully this works. No. Oh, yes, sorry. Yes, we do. What's he done? Hey. All right. Here we fucking go. So, called this shoulder impingement, aka mum, my shoulder's fucked. But that's our topic for today, with a bit of Nick Rewalt with his shoulder being fucked. Yeah, 100%. Hopefully this works. Why is our clicker not working? Stop it. No, it does now. It does. It was just turned off. It was turned off. So the reason we wanted to go shoulder impingement, because Goldie mentioned shoulder bursitis, and then I was like, cool, we can look at bursitis. And I was like, let's start looking for bursitis again. I was like, well, that leads to this, which leads to this, which leads to this. So we're going to go broader, the whole shoulder. I'm going to go full nerd mode in some areas, and then there's going to be some bits which is strictly opinion based, but I'll reference that before I say it, so you don't think it's gospel fact. Any questions as we go, obviously yell out, and we'll go from there. Our overview, which obviously I stole from Carl's slides, so that's what we're going to cover, how I usually roll. Our terms though. So this is where I really like shoulders, but this is where shoulders get really, really confusing. So if you did a Google search and you tried to look up what is the definition of shoulder impingement, there's the first four, right? Kind of the same, but at the same time, they're kind of different. So you got some, okay, we've got a structural narrowing of the subacromial space. Cool. Maybe it's impinging. This word impingement pops up a lot, right? If someone wants to take a stab at what the definition of the word impingement is, even that becomes challenging, right? So these terms, they get used interchangeably, very similar to what Carl was speaking about last week. Is it tendonitis? Is it tendinosis? Is it a tendinopathy? Some of them are more umbrella terms. Basically, if we think about how people sometimes describe knee pain and they say patellofemoral pain, basically means, your patella and your femur, hey, that's for my knee, pain hurts, knee hurts. It's kind of the same thing here, right? What we can probably agree on from this, it's like there's going to be a pinching or compressing of tissue in that subacromial space, so in the joint itself, which is causing pain, and it's typically going to be associated with when we go overhead in motion, right? But that's a really important thing to start off with, that when someone comes in and they're like, I've got shoulder impingement, what they think shoulder impingement is and what we think shoulder impingement is might not be the same thing. What their physio thinks it is and what we think it is might not be the same thing. There's a lot of things at play here, which we'll go through. That makes sense in the sense that it doesn't make sense. Great. You're picking up what I'm putting down? Great. So if we go to our next layer here, rotator cuff syndrome. First off, I love that it's called a syndrome. That's fantastic, right? But again, very similar to last week with the tendon terms. Sorry. So rotator cuff syndrome is specifically referring to an issue with the rotator cuff itself. Okay, that can also be a type of shoulder impingement, by the way, but the inverse is not necessarily true. Okay, so when we say that subacromial impingement syndrome, it's basically one of those rotator cuff tendons is being compressed in that space. That's causing pain through movement itself. You can also have a tear to one of the rotator cuff muscles, which would not be rotator cuff syndrome. That should be a specific tear to a specific muscle, right? Oh yeah, this is my favorite bit. Bursitis, which we started with. Does everyone know what a bursa is, by the way? Okay. It's a little sack of shit, right? It's a fluid-filled sac that sits in the shoulder. You have one in the hip as well. It is actually there as almost like a cushion within the joint, but when it gets compressed, irritated, it gets inflamed, which can cause pain. Okay. Don't have bursas per se in our knees, but we do have fat pads in the knees, which act in a similar kind of fashion. Bursitis is very, very commonly called shoulder impingement syndrome. Okay, so those two are used interchangeably all the time, but there are different forms of shoulder impingement. Okay, so a lot of the time someone will go to a physio's like, yeah, you got shoulder impingement. It's like, oh, cool, was that bursitis? Is it this? Is it that? Sometimes we don't really know. Okay, so that's just something to be aware of. Bursitis by itself is typically going to be a symptom rather than the root cause of something. Like, if our role as coaches, I think anyway, is to figure out what's caused it rather than just treating the injury itself. And with bursitis, it's like, okay, cool. There's this little sac of fluid. It's inflamed in your shoulder joint. Our mind should go to why. Because there's not much point if we go, yeah, you can take some anti-inflammatories and rest it. And yeah, the inflammation will go down. But we don't want to do what we were doing before and then just end up in that same scenario over and over and over again. Does that make sense? Any questions on that so far? Different terms, etc. Right. I'm making assumptions here. Rotator cuff, we're all familiar with what our rotator cuff is, what it does, what they are. Great. Good. Terms, my last term, frozen shoulder, little Elsa. I'd probably put this in a different category, but I thought I'd throw it in today just because of the demographic that typically experiences this. Would be 40 to 60 years old. It's far more common in women as well. Considering we have a lot of 40 to 60-year-old women in the gym, fair chance we're going to encounter this one. Okay, so it's a tough one. It's typically what happens when you've got an impingement that is there for an extended period of time. Okay, so adhesive capsulitis is the technical term. So if you think about adhesive, capsule, glue, capsule, everything just gets stiff and stuck together, right? The most obvious symptom of this is a reduction in the range of motion, more specifically the passive range of motion. So you'll hear people be like, oh, I can't get dressed in the morning as easily because I just physically feel like I can't get past here. If we help them, yes, actively, they should still be able to get into that range, but passively, you see they just can't lift their shoulder past a certain point. Even when Marty had that thing a little while ago, and he was, you'd be just doing this type of thing, because frozen shoulder can sometimes come as a kind of flow-on effect of a different injury in the shoulder, right? Especially for people that are a little bit older. Like that joint capsule will just kind of stiffen up and seize up. With actually treating it per se, it's very, very difficult. So it typically lasts between 1 and 3 years, right? Frozen shoulder. There's no universal, hey, this is how we go about it, because the varying in symptoms and duration is massive. And I got this from a meta-analysis from old Lee et al. It was pretty funny. The study was by Lee, and Lee. And I was like, that's like, I don't want to be stereotyping, but I was like, classic. Some people will spontaneously get better. One day, can't lift my arm up. Next day, guess it's fine. Super random. Sometimes people will need surgery to actually like open that joint back up again, and they'll cut tissue out, etc. So treatment definitely needs to be patient specific. So for us, it's very much going to be defaulting back to that trainable menu, finding what they can do and working from there. More often than not, somebody that has frozen shoulder, they've been dealing it for a while, they'll typically be seeing some other form of allied health as well, right? Prevention, definitely the best thing with frozen shoulder as well. If somebody has shoulder impingement and they leave that unchecked for an extended period of time, they are far more likely to develop frozen shoulder, which is what we don't want. So complete rest, as we always know, is not always the best course of action. Any questions on that one? It's a little bit of a left field one, but I just thought I'd throw it in there just in case. Anatomy. So this is the technical stuff, and then there's me giving my take on it. So impingement, where's my laser pointer? Oh, you can't see it on the white. But basically, in here, a whole bunch of shit's getting rubbed together. It's getting irritated, it's getting pissed off, right? So you've got your rotator cuff tendons and muscles. The bursa is that pink thing, was. So that little fluidy kind of thing. You've also got your AC joint in there. You've also got your biceps tendon that's inserting in around there as well. So there's a lot of stuff going on in quite a small area, okay? So, which we'll get into in a minute, but one of the bigger challenges with shoulder conditions is there is a lot of different structures in there, okay? And if one thing gets irritated, everything else can feel irritated all at the same time. It's sometimes hard to pinpoint where the specific pain is for people. And you know, you go, does that hurt? Does that hurt? Does that hurt? Does that hurt? It all hurts. So that's a kind of common one. Scans can be useful, but often they're not that useful. Why do we think that maybe they're not that useful? There's definitely that. You get someone who's, you know, 40 odd, they've been somewhat active. It's like, guess what? That scan result's probably not coming back that everything's 100% hunky-dory. So you go, oh yeah, it could be that, it could be this, it could be that. That's one reason. One of the other reasons is outside of something that's super, super obvious, it's not going to change what you actually do. So you go like, let's say it's a rotator cuff tear, right? You could make an argument that which one's torn could somewhat change what you do from a treatment point of view. Sure. You could also counter that argument by, you'd probably figure that out pretty quickly just by going through the motions and training them. There's that. Also, if it's a bursa, if it's a rotator cuff syndrome, if it's this, your first 4, 6, 8 weeks, they're probably going to look really, really similar. Okay, so yeah, great. We now have a better idea of what it is. Cool, we're still going to go do the exact same thing that we were going to do anyway, which is finding things that you can tolerate and then slowly progressing them over time. Does that make sense? Sometimes people just love getting scans though. So, yeah, we'll let them. Any questions on the anatomy side there? First slide. Great. Ooh, animations. There we go. So, with our typical impingement syndrome, right, there is this term which they call the painful arc, where movements are typically going to hurt the most. So we've got our abduction test here. So it'd be from that 60 to like 120 in this range here, particularly with load. If you've ever had a shoulder issue, you get physio, one of the common tests is like, you know, push out against my hand, where does it start to hurt? It's like, yeah, guess what? It's going to start to hurt there. You're going to have like very limited strength. It's going to be painful in that range. Typically, once people get to here, up over here, oh yeah, that's actually not too bad anymore. Why? I would make the argument that your trap's just doing all the work there anyway, so there's less load through the shoulder. So that's typically where it's going to be, somewhat similar in front of the body. Anecdotally, I've found people typically experience pain a little bit faster. So before 60 degrees, if pushing out in front of the body. With that, we can kind of see why, if we think again to that bursa or even the rotator cuff, even if you put the hand there and you start to lift up, actually do it. Come on, Loss. Put your finger there, kind of palpate a little bit, do a little test, feel, it starts to move. In there, you got less space. The bottom, you can kind of put at least your full finger in there. By the time you get to that kind of 60-degree mark and move up, there's far less space. Because there's less space, it's getting compressed. That's why it's causing pain. That makes sense? Great. So shoulder pain itself presents some unique challenges, which is kind of why I like it. But firstly, it's because there's a large range of motion of the shoulder, right? So it's not meant to be a stable joint. Okay, so shoulder stability is a little bit of an oxymoron. Like you don't really want your shoulder to be, like, yeah, we want it to be stable to a degree, but what we really want is it for it to be able to move around and flop and do all the rest of it. Like if you compare it to your knee, for example, typically we want our knee to be able to bend and extend. Like that's it. Shoulder, not the case, right? So there's far more range of motion there. There's a lot more actual structures as well in the shoulder. How many shoulder joints do we have, for example? Pop quiz. Hit me, Loz. Hit me, Sam. 4. So you got your glenohumeral, you got your AC, acromioclavicular, you got your sternoclavicular, and you got your scapulothoracic. They're like your 4 common shoulder joints per se, right? I don't actually. Oh, maybe I do. Kind of. All right, so glenohumeral is like your ball and socket. AC, this fucker up here, so it's the point on your shoulder. Your sternoclavicular, end of your sternum where it attaches to the clavicle, and your scapulothoracic, basically your shoulder blade itself. Does that make sense? But you're right, I should have a graphic, Loz. I'll do better next time, all right? I'll do better. So with that, obviously there's 4 joints. There's a lot of tendons, ligaments, muscles, like even the rotator cuff itself, right? There's these 4 little muscles in there as well. So the thing that it's probably most in common with, it would be our hip, okay? It's our other ball and socket joint. It's designed, obviously, to have more range of motion, etc. So hip and shoulder, you'll find those same kind of challenges with in general. The third thing that makes the shoulder challenging is there's a very high possibility of false positives from assessments, particularly if somebody's in pain. So that's where if you are screening someone, you're like, I want to see, let's like see if they test positive for like rotator cuff impingement. Well, cool, you could do it, but that same positive could be indicative of a bunch of other things. Even if that's not the root cause. Bursitis is probably the best example. It's like, cool, this test shows that you probably have bursitis. But that could also be testing positive for a bunch of different reasons because everything's inflamed in quite a small area. Does that make sense? So sometimes those typical screening tests, like even, push up against my hand, you've got pain in this range, that doesn't really tell us enough, or it's not enough to rule out certain things, if that makes sense. So from our point of view, that does become a challenge because a misdiagnosis of a shoulder injury is very, very common. So someone will come in, oh, the physio said I have bursitis. Cool, if we just take that at face value, they have bursitis and you just think it's just bursitis. Well, a month later, it hasn't gotten any better. Okay, cool, I'm gonna go see someone else. Oh, they've told me I've got rotator cuff syndrome, so I need to be doing this. Oh, okay, cool. You go and do that. Hopefully that next person's right, but you don't know. Eventually, they go get scanned. I've got arthritis in my shoulder. It's like, okay, cool. All these different things at play. So with that, we don't want to be overly reliant on any one assessment. We kind of want to look at the whole body of it, if that makes sense. Anybody got experience having a false diagnosed shoulder? No? I spent about 6 months doing a rotator cuff rehab, and then turned out I had a whole bunch of bone floating around in my AC joint. They're like, you need to get that cut out, champ, or it's never going to get better, no matter how many banded external rotations you do. So yeah, but it does happen. We can obviously minimize those challenges though. So obviously we always want to work in with the allied health, have that integrated approach. If nothing else, it just means that we minimize the chance of Chinese whispers between physio tells client something, client hopefully remembers, but they add their own interpretation of that. It's obviously not their field. They come and tell us something, and then we're going, okay, is that exactly what's been said? We don't really know. So if we can cut them out, we can go straight to the source, cool, get on the same page. And look, if the person's an idiot, at least we can get to that conclusion faster and be like, all right, let's not put too much weight on what they've said. That does occasionally happen. Exercise modification, that's going to be a big part of it. So finding that trainable menu. And then with the shoulder, actually with pretty much any injury, but we'll stick to shoulders here, being guided by the process is really, really important and by the progress that they're making. So we don't want to get too bogged down in, okay, if you have rotator cuff syndrome, this will be 4 to 6 weeks, and you will be at this point by this point in time. We have no idea if that's going to happen or not. All we really know is, okay, you're able to tolerate doing this. This is a good idea for X, Y, and Z reason. We're going to do this. We're going to see how it goes, and then we're going to adjust as we need on a week-by-week basis, or even a day-by-day basis, depending on what state they're in, which is pretty much how we approach rehab in general. Does that make sense? Great. Stolen car slides again. This stuff is always going to be correct. So the reason I left it in here is because it's never a bad thing to just always revisit. Like, okay, we've got a slightly different context here between, we're looking at like elbow tendinopathies versus shoulder injuries. That's still true, right? We're still trying to rebuild that capacity over time. And we definitely want to break this one down. I think this is really, really important for shoulders. Like, not that it's not important for every other injury, but really important kind of framework or model to look at shoulders through. So it's like we have the injury, it causes pain, we have that muscle inhibition, they move worse, which is causing injury, which is causing pain. This is really, really common for shoulder stuff, which I'll get into as we go. I think, as all things in rehab, like how you do things matters more than like what you do, if that makes sense. But with the shoulder stuff, I think it's particularly important because you can do the right exercise the wrong way and it is not doing what you think it's doing. Cal knows what I'm saying. This, again, money. Like, especially with shoulders. Like, I've used that analogy all the time. It's like, oh, it hurts when I bench press. It's like, well, it hurts when you bench press 100 kilos. Does it hurt when you bench press 40 kilos? No. Okay, maybe let's start bench pressing 40 kilos and slowly build our way back up. That's a very sensible strategy for pretty much all injuries. Build the capacity, gradually expose, particularly, if it's bursitis, it's going to be very temperamental. It's based on inflammation. So doing too much too soon, we're going to take a step back. If it's rotator cuff syndrome, again, very similar to a tendinopathy, it's that same kind of process. And then, obviously, load management, exercise, modification is pretty much always our approach here. So who this is. Here's me semi-taking the piss. Have you got someone come in? Kids? Oh, okay. Well, easy. The ladies. I won't hit Sam with the laser pointer. That would be rude. I thought I was going to get him with the laser pointer. On the annals. Oh yeah, here's me taking the piss again. Yeah. Yeah. It's like here. Yeah. You could, yeah. I don't know about that. Yeah, anyway. All good. All good. This is me taking the piss, but here's a fairly typical scenario, right? Shoulder pain. We are the red, or I'm the red. I'm not trying to be racist here, but the other person's black. But anyway, so you got someone comes in, shoulder pain. Oh, I'm getting massage and manipulation from my osteo on a weekly basis, and I'm putting some deep heat on there. It's like me being like, literally none of that is going to be useful for shoulder impingement, right? Like none of it. But hey, that happens all the time. So I've been given stretches to perform as my pecs and lats are extremely tight, which is what's led to the problem. It's like, fucking is it? That's an interesting theory. That happens all the time. And that's like going back to, not that we're talking about it today, but I always try and think about it, that whole pain science lens to be like, what people have been told is definitely going to impact their own perception of what's happening. So if somebody is told that they have X, Y, and Z issue, it's very hard for us to be like, okay, well, we're going to like kind of work with that and reframe that over time, which is why it's frustrating. But yeah, it's like, okay, that perceived tightness is probably not relevant. And yeah, you stretching the shit out of all the areas around your shoulder when you've got something that is heavily temperamental and likely to be irritated, like maybe not the best strategy. My physio told me to do band exercises and wait 3 weeks before lifting weights. It's like, oh, great. You could, maybe do something now and not wait just this random period of time that is clearly made up before you go and lift the weights again, right? Particularly if we have something, if we make some assumption that it's a decent chance that it's a tendinopathy, we do not want to go from doing banded rehab stuff straight to lifting weights. That is the absolute last thing we want to do, right? So a lot of physios, this is my controversial opinion, physio, osteo, whatever, they will give people, especially with shoulders, a list of 5 or more exercises with a bunch of reps because they are literally just throwing shit against the wall because they don't know what the issue is. But it happens all the time. Yeah, just do these ones. And then you see someone come in the gym and they do it and they're like, yeah, physio said to do this. It's like, fuck's sake, like doing hundreds and hundreds of reps of something like that, in what universe is that the best course of action? Like, it's just not. So we want to be able to go, okay, let's be a little bit more sensible than that. Here we go. So if we are looking at rotator cuff strengthening, using correct form is really, really important, right? And it's where like people roll their eyes all the time, but it's like, I hate seeing shitty like band and external rotation. I hate it. I'm like, do it properly or don't do it. It's doing you no good if you're just doing a shit version of it. Don't train to failure, right? Like it is literally we're dealing with something where pain is caused from inflammation. What's the most obvious way to get inflammation? It's to overwork it. Don't overwork it, right? We're not like training for hypertrophy here, right? We're trying to build strength and tolerance in the tissue. So we want to stay a fair way away from failure. And we want to think about the rotator cuff being responsible more for stability and function around our shoulder more than any one specific movement, right? I'm not saying there's not a place for external rotation. There is. But I'm saying it's not the be all and end all of what the rotator cuff is actually responsible for. What we want our rotator cuff to be responsible for is like when we're doing a bench press, our shoulder is stable, right? When we're lifting weights around or when we're overhead, it's holding a stable position. When we're throwing a ball, it's stable, right? It's keeping everything in the right spot. That is really what we're chasing. And I think this is a Mike Reinold quote, but he's like, do things correctly before you do them a lot or under fatigue. So basically saying like, stop with the 4 sets of 25 of this. It's like, if someone's just going to do a shit version of it, I'd rather they do 1 set of 10, but they do it correctly. And then we slowly build that up. Does that make sense? So I'll go through some actual exercises here. We can get a little bit more fun. Sam, can you have a kettlebell? A little one? Good. With this last one though, we'll do a little pop quiz again, Loz. Why do you think that the form matters so much? Yeah, a little bit of that, definitely. If we, like, it's even when you go rotator cuff, like you want to be a little bit more specific because some of them are obviously responsible for externally rotating the shoulder, some of them are responsible for internally rotating the shoulder. But if, for example, we're doing this real shitty version, it's like, okay, if we're trying to strengthen our external rotators, the last thing we want to do is just dump into internal rotation every rep, especially if we're going to do 100 reps. Because 100 reps of a rehab exercise is done with a shitty posture is possibly going to irritate that structure despite the fact that the exercise is designed to strengthen it. Does that make sense? So like with a lot of this stuff, we can probably get better outcomes for clients by not changing the exercise they're doing, but just being the ones that actually watch them. Because that's the one thing physios never do, right? They just write the exercise on a piece of paper. Good ones now at least have apps, but old mate Brendan, he's literally got a list of exercises. How good do you reckon his form is at home when he's doing it? If he's even doing his exercises. Absolute trash. Like how many times do you have to tell someone to be like you've still got people that do external rotation with a dumbbell this way. It's like, seriously, like gravity obviously does not work that way. You're going to have to come to here to get it to work. People don't know. So that's kind of our role to actually, okay, posture, correct position. If we're externally rotating, let's make sure we're externally rotating. Let's make sure we're not doing this. because the mechanism of injury, especially if they're an athlete, like they're throwing all the time, which is where I learned much of this stuff. It's like, yeah, because they're always rolling into internal rotation and they're doing that hundreds of times a day at training. So do we want to give them a band and be like, just do a few hundred more times? Surely that'll fix. Hopefully that makes sense. The bottoms up press. Come here, Loz. Come here. So I couldn't find it, and also I guess a video for static movements, not the best one. But with this, and like typically you'd probably go half kneeling, but it doesn't matter to start. Here he is. Good. You can go in. Yeah, yeah. I'm not getting up on the bed though. Yeah. Mate, it's important to get your prostate screened every 6 months, you know, like don't let it go. But with this, static holds are where we like to start, right? Before we go to actually repping these out. So the bottoms up press is really good. 2 reasons. It limits load, which we love. Number 2, it gets literally everything to fire up just to hold that stable position, which means even if we're wrong, we're probably right. In the sense of it's going to strengthen everything at the same time, right? The other reason I like movements like this, as we know, strength is joint angle specific. So as much as this stuff can be great, if you take someone who's somewhat strong, this maybe isn't enough of a stimulus, right? Versus, hey, we can make you strong here, and then we can start repping this out, which means we're going to be strong through that full range that we actually want for the activities that we're going to do. So it kind of bridges that gap a little bit more. But if you just go 90 degrees, Loz, start there, yeah, give us your best. And then we're just going to get her to hang out here. And we're going to pay attention to how she does it. This is actually pretty good. But if, for example, she started like really rolling forward with the shoulder, doing a real shit version, we're just going to stop her. Like we're not going to let her hold that for 20 seconds. So just say stop, reset, let's get back to that strong position. This is where as well, like tactile feedback works really well for people. So rather than be like, I want you to externally rotate, I'll just be like, Lars, is it okay if I touch you? Great. She'd say, yes, please. And then you just pop them in there, go, cool, I want you to hold it like that, and then do it, etc. So holds from that position is good. And then next progression would be holds all the way up. It's like an actual locked out carry. Yeah, and this would be a real interesting one because you'll be able to see how people compensate as well. Not bad, Loz. Good. You know when we do like a half kneeling press and people will be doing the, oh yeah, oh yeah, oh yeah. They'll be like, it's good, yeah. You're like, not so good, champ. But we want to do it, for me anyway, I want to teach them what that position should look like and should feel like before they start repping it out. Because then they know, cool, I know what this is and I know what this is, so I know what point A is and what point B is. And they can kind of fill in the blanks themselves. Versus if we go straight there, not saying it's bad, they'll probably get there eventually, but it's harder for them to perceive what like the correct end position is, if that makes sense. We should do that for all exercises actually, anyway. Horizontal abduction. So this is a good one. This is the only reason I have this bench, by the way. Sam, you can jump up here. Get up here quickly, son. This is kind of the better version of a YTW, right? So I actually really like YTWs, by the way. And in a group setting or like as a broad brush strategy, I think they're really, really good. The reason we'd go prone and single arm, why do you think it is, Sam? Yeah, exactly. So if somebody has an issue on one side in particular, it's like, cool, we can see is there a difference from one side to the other and all the rest of it. So what we do, if we didn't have a bench, by the way, you can do it on the table, you can do it on a bench, or you can do it on the floor. But the way that we get Sam set up is actually eyes that way. That way. And then we get him to do his Y raises. So you're gonna go straight with the arm, shift a little bit further over, so you're like fully hanging over. Yeah, great. And then you're just gonna do like your T raises. Great. And the good thing with this, we can do a few little cues. So I could like place my hand here and say, I want you to do it without there being any gap. Because if Sam wants to cheat, do a few shit ones, there'll be a big gap there. So we can isolate a lot more. The other fun thing we can do here is we can play around with his shoulder by controlling his thumb. So if we go thumbs towards him, that's one position. Or we can get him to go, let's go thumbs up and try and work the same thing with your arms straight. There we go. Nice. And we go really controlled and passive here. And usually what I'm trying to cue people to do is to avoid using momentum as much as possible. So this is not a high velocity strength movement. It's very much low level. Cool. Let's work this for a little bit. And you'll find sometimes people that are reasonably strong, they'll do like 10, 15 reps with no weight whatsoever, and they'll be unable to get to that same range. It's like because they're just fatigued already. So that can be a really, really good one to do. And you can also do the same thing in with a Y raise as well. So like Ys and Ts here are pretty much your go-tos for the most part. And then I would probably start just with the abduction and then start trying to bias the external rotation or internal rotation, whatever you're actually trying to achieve for the exercise. Most of the time for us, we're probably going to want to bias external rotation. For the 99% of people we encounter, like they don't need more internal rotation in their daily life, right? Like they just don't. Does that make sense? So that can be a really good one if you've got anybody who would I do? Like even, for example, old mate Steve Kennedy, when he comes back from surgery, it's like, cool, you could just do a few rounds of that just on your injured side before we go into and just do your general like shoulder prehab warm-up stuff. And it is, as opposed to, you know, someone comes through and you've seen how some people do YTWs, right? And you're like, come on guys. It's the same thing. It's like just controlling how they do it more so than what they do. So it just prevents this big flailing action, and it means, cool, like, well, what are we trying to actually get out of the exercise? How do we make sure we get that out of the movement? We introduce more constraints, which in this case is only doing one arm and making sure that their whole body is prone when they do it. That make sense? Any questions on that one? Great. Oh yeah, alrighty. Loz Dog, you're up. Actually, I might get Carl for this one because I don't want him to feel left out. I would probably, by the way, I would do cable as opposed to band on this. But we're going to go 2 half kneeling external rotations. So the first one we'll get is just the normal one. So we'll get Carl to face the wall here. We'll go right arm just so everybody can see. So with this is a really good external rotation drill. I really like this. Anybody who's an overhead athlete or who wants to just do overhead activities, I like versions like this as opposed to just banded external rotation. Why do you think that is, Loz? Yeah, yeah, it puts them in a more similar position. Yeah, absolutely. So what do you think we'd be looking for here, Loz? Okay. 100%. So what I look for here is I don't need Carl's elbow to be the same size, like because people go same height as shoulder. I don't actually want that because if we go technical term, his shoulder joint's probably here, so he actually is in line with there. We don't actually want it the same side, same height as his clavicle because he will just bias trap all day long. So we want to keep him here, and we want to make sure that he doesn't dump too much into internal rotation as he comes through. If he loses posture, yep, and if he tries to compensate, you'll see that all the time. People will lack the strength and they'll start doing these bad boys. So we want to make sure, especially if we're doing a cable, we're keeping a weight where we're only getting that external rotation strong position and we're not dumping forward and there's no compensation as he starts to lean through. So that's one version. The other variation, which I also really like, is when we go to a 90-degree external rotation, which is where we get real fancy. So when you get Carl to set up side on for this bad boy, yes. So bang on like so, right? Same, but different. So from here, very similar approach. We're going to get him up in that same position. And what we're going to do here is get Carl again to go for that external rotation. And I'll generally actually keep the first few reps anyway, keep my hand there just for a little bit of feedback for him. So go keep that same degree of pressure into my hand as you're going through those reps. This one will feel quite different. And it's a really good one if you've got somebody who keeps on compensating in that first variation. Switching here is a good one because it makes it harder. Like they can still go into internal rotation, but for them it feels more obvious. If you're going this way, they'll be like, yeah, no, I feel like I'm doing pretty well. Because all they're thinking about, it's like, yeah, it's burning here, that's good. They don't really get it. As soon as you switch to here, it's really hard because they can't compensate in that same degree. We're just adding another constraint, right? I'll typically use both, but if somebody has been struggling a little bit, it's like, cool, we'll go for this version just because it adds that extra constraint. Makes them feel a bit fancy too. Like both of those, especially like we're not going to do that in a group, but in semi-private, I would go both of those over this. Why do we think it is though? There's definitely that. It's also something that they haven't likely done before, so they're going to pay attention, so they're going to be more willing to learn it, and it's more challenging from the get-go, right? So it feels like they're achieving something through the movement. They're less likely to just fuck around and go through the motions. There's definitely the structural benefits as well, but from a psychological point of view, I think if the physio's already told them to do this, it's like, fuck, this is boring as shit. Why do I keep on doing this stuff? Versus like, oh yeah, fuck, look at me go. Like, this is real professional. That's me, just gaslighting people, but hey, that works. This is the basic shoulder flexion test, which I know we've been through before, but like, I don't, as you guys would know, we don't really do a lot of like general screening tests a lot of the time, because if we're not going to change what someone's going to do, what's the point of it? This might be an exception. So seated is one way to do it. The other way is literally just get someone to walk against a wall. We all know this screening test, shoulder flexion. No, so if you come over, Loz, you might have to go seated under TV. It's literally going to be keeping your back in contact with the wall. I'll get you to sit. Come on.
Huh?
Sit.
Sit.
Come on. Stay. So you're going to go butt to the wall, button back. And from there, I'll get you to bend your knees. Great. And from here, all we're going to do is overhead, reach back, and try and get your hands to the wall. No, that's actually quite good. Yeah. So for you, we'd obviously try and get them to go straight and all the rest of it. That's a pass, by the way. You're fine. If somebody can't do that, that immediately rules out a bunch of exercises, particularly if they've got shoulder pain. It's like,
So would they get like this?
oh yeah, they'll be like, or they'll like arch heap through the low back.
Oh, right. Okay.
Right.
What's the wall stops that?
Yeah. So it just means like for a lot of movements, like I think we've done it before, like if someone can't do that, well, guess what? Like you're not going to do a barbell overhead press, are you? Because like it's not going to be a mystery to us that your shoulder hurts or your neck hurts or something like that. We're going to use an incline bench. We're going to set you up to a point where you actually have the range. But for this, it's like, I did this with, what's his face? Ash Price. He's had those neck issues. And I was like, mate, you can't do chin-ups. Like you just can't. You have nowhere near the range that you would need to actually do a chin-up. And every time you try and do a chin-up, you're compensating by using your neck, and then your neck flares up. Like, so at the moment, it's just not something that we should be doing. And you'll see this one, I think, put in particular, because there's a lot of people that think, that push-pull thing still kind of has some weight, but people will put like vertical pulls in the same category as horizontal pulls, which I don't think it should be, for one main reason. Like, what's our main muscle for the chin up, pull down, etc.? It's the lats. It's like, what is one of the main roles of the lats? It's to internally rotate the shoulder. So if you've got somebody who's already got shoulder impingement, we're just, once again, feeding into that same bias of like, okay, we are again in internal rotation. So we want to bias that, particularly if somebody doesn't have the range for the shoulders. Like, what's that going to look like at the top? Like, their shoulders are quite literally going to look like this at the top of each rep. So again, not something that we really want to play around with. Does that make sense? That's a real basic one. It's like, oh, my shoulder hurts when I do this. Cool. Can you put your arms overhead against this wall? No, you can't. Sweet. We're just going to find a different way for you to do that. We can hit the same muscle groups. We can do everything like that, but you just don't have the range to do it. The next one will be like, how do you increase the range and the shoulder flexion? Like, what can you do through like the T-spine and stuff like that? Which maybe we should talk about that next week or something. Yeah, absolutely. And this is my last slide anyway, which is where I dumb it back down to do all the exact same stuff that we would already do. To say this, working with shoulder pain in practice, you're going to pick some upper body movements that are tolerable. Examples, dumbbell bench press, or incline, or an overhead press. Landmine press, great. Machines, if you had machines, you could definitely use machines. Rows, pull downs, pull ups, I've got those asterisks because again, if they don't have the range to do it, I probably just wouldn't do it. Then we're going to find an initial rate that you can tolerate for 12 to 15 reps, and you're going to slowly build up from there. That's literally it. And it's where like you don't need to know all the answers, have all the scans, have the specific diagnosis. It's like if you go, okay, bench press hurts my shoulder, cool. Can you do dumbbell bench presses for 15 reps with this weight? Okay, sweet. Doesn't cause pain? Sweet. Let's do that, and let's slowly increase the weight next week. That's the entire process. Yeah. I think that's all I got. It is. And Carl's Chuck Norris. It's like, we're definitely keeping that. Any questions though?